Hi, I'm Dr. Vanessa Salcedo, Director of Wellness and Health Promotion at Union Community Health Center, and welcome to our Grand Round series. Today we have the pleasure of having Leah Hill, who is our Director of Audiology, and she'll be going over the basic principles of audiology and how we can better serve our patients. Thank you.
All right, good afternoon, thank you. As Dr. Salcedo said, my name is Leah Lockley-Hill and I'm the Director of Audiology here at UCHC. We're also at 3rd Avenue on the 7th floor, and I'm glad I get the opportunity to discuss the audiology department with you. So first of all, I'm gonna define what an audiologist is. An audiologist is a specialist in hearing and balance disorders. The primary role of the audiologist is to, 1, identify and assess hearing and balance disorders, 2, habilitate and rehabilitate hearing and balance disorders, and 3, the prevention of hearing loss. I just want to add that for infants and children, the primary goal is to focus on hearing, not so much balance. So part of what we do as audiologists is assess hearing. And I think it's important to know, how do we hear? Well, there are 4 parts of the auditory system. 3 peripheral, and the 4th one is in the brain, the central auditory system. So the 3 parts that are peripheral are the outer ear, the middle ear, and the inner ear. And the part that's in the brain is the central auditory system. The outer ear has the pinna, the ear canal, and the eardrum. The pinna, which is visible, is the part that plays a small contribution in the localization of sound. Once the pinna gets this sound, the acoustic stimuli, it goes to the ear canal. The ear canal is about 1 inch long and it's S-shaped, and what the ear canal does is it continues to funnel the sound to the eardrum, or the tympanic membrane. The ear canal also plays a role in preventing debris from falling into the ear canal by producing earwax. So you have the outer ear, the pinna, which takes the sound, kind of localizes that sound, brings it into the ear canal, which funnels it to the eardrum. Once you're in the eardrum, what happens is that the sound vibrates the eardrum, which causes it to change to mechanical energy. Once it's changed to mechanical energy, it goes to the ossicles. The malleus, which is one of the bones in your ear, in the middle ear, it's also one of the tiniest bones in the middle ear. The malleus takes that mechanical energy and continues to transmit and process the signal. From the malleus, it goes to the incus, and from the incus, it goes to the stapes. Once it gets to the stapes, that stapes takes that mechanical energy and sends it via the oval window into the inner ear. Also in the middle ear is the eustachian tube. And the eustachian tube is a tube that connects the nose to the middle ear to the back of the throat. And the eustachian tube helps to equalize the air pressure from the middle ear to the outside environment. So you have the outer ear taking the sound, bringing it to the middle ear, which changes it to the mechanical energy, and then it goes into the inner ear. Now the inner ear has 2 sections, one for hearing and one for balance. So we'll talk about the balance portion later. Right now we're going to focus on the hearing section of the inner ear. And the hearing section of the inner ear is the cochlea. The cochlea contains hair cells. And those hair cells, they bend slightly in response to different kinds of sounds. And in bending, that's changing that mechanical energy that was in the middle ear to electrical impulses. Sorry. And those electrical impulses goes to the central auditory nervous system, which we use to interpret sound the way we hear it. So you need to have a normal outer ear, middle ear, and inner ear in order to process sound. Finally, it goes to the central auditory system. The function of the central auditory system is to process signals for recognition of sounds, sound localization, auditory attention, and pattern recognition. So what happens is, after it's in the inner ear and it's being changed into those electrical impulses, it goes to the 8th nerve, the auditory nerve. Once it goes to the 8th nerve, the auditory nerve, those nerve fibers, there's about, I think, 25,000 nerve fibers. They continue on to the brainstem, and from the brainstem it goes to the auditory cortex. And it's in the auditory cortex, the cortex of the brain, that we interpret sound based on our experience and on the fact that our outer, middle, and inner ear functions normally. So I'm going to just show you a brief video because I'm one of these, because I work with the deaf a lot and tend to be very visual. So I'm going to show you a brief visual of how the auditory system works. Oh, it's not working. What happened? Help Elkins, it's not working. Exit. I don't hear the sound.
The speakers you are listening to right now are vibrating, flexing in and out, causing a wave of pressure through the air. The frequency of these waves, or the speed at which the sound creating surface moves back and forth, affects the pitch of the sound. The level of air pressure in each wave is directly related to how loud the sound is. The outer part of our ear catches these waves. It faces forward and has a specially designed structure of curves, helping us to determine the direction of the sound and also emphasize the frequencies used in human speech. Now that the sound waves are caught, they travel through the ear canal and strike against our eardrum, a thin membrane about 10 millimeters wide. Now that we receive the sound, the middle ear transfers this energy. The smallest bones in your body, the malleus, incus, and stapes, start in motion. The malleus is attached to the eardrum, and as the sound travels along, the force is amplified by leverage until it arrives at the stapes, which acts like a reverse piston, creating waves in the fluid of the inner ear. The most significant increase in pressure is caused by pneumatic amplification. The face of the stapes has a surface area of about 3.2 square millimeters, while the eardrum has a surface area of 55 square millimeters. Using this, along with leverage to the malleus and incus, the final pressure is 22 times greater than when the sound first arrived. Now we come to the most complicated part of the hearing, the cochlea. In reality, it is coiled up, but it is easier to understand straightened out. There are actually 3 chambers inside, but let's take a look at the central part. The stapes is causing pressure waves to travel through the structure. Along the inside wall is about 20 to 30,000 reed-like fibers. As the waves move along, they encounter fibers with the correct resonant frequency and energy is released. These fibers aren't actually what give us the signal that we heard something. There's a special structure next to these fibers containing hair cells. When the fibers resonate, they cause the hair cells to move, which then sends an electrical impulse to the cochlear nerve and onto the brain. Certain pitches of sound will resonate in specific locations, and louder sounds will cause more hair cells to move. Our brain interprets all this raw data, making it possible to enjoy things like music or an engaging conversation. Just to think that all of this is happening in your head right now at full speed. This is just one of the amazing systems found in the human body that go far beyond our humble human understanding.
So that's just a visual depiction of how sound is processed. So, as I said before, you have to have a normal outer ear, middle ear, and inner ear in order to interpret and understand speech clearly. So one way an audiologist is able to determine whether or not there's a problem with the middle ear is by using a device called the tympanometer. And the tympanometer conducts a test called tympanometry. And tympanometry helps us to rule out the presence or absence of middle ear pathology. And at this point, I'd like to introduce my colleague. She's a professor at the Long Island Consortium, and she's been our per diem audiologist for quite some time. So thank you, Ianthe.
Good afternoon. Thank you so much for welcoming us here today to give you this audiology talk. As my colleague Leah mentioned, it is important for the audiologist to measure the health and integrity of the outer, the middle, and the inner ear. And we have diagnostics information and also equipment that we utilize. And as she explained, the tympanometer is able to give us measures of the health of the middle ear. So the main function of tympanometry is that it helps the audiologist evaluate the physical and the functional properties of the middle ear. And with that diagnostic information, we are able to characterize the health of the middle ear, what's happening behind the eardrum, and what happens as sound travels through that cavity. And so it gives us specific information regarding the health of the middle ear structures. The main benefit is that it will provide the audiologist with medical information regarding pathologies that do impact the middle ear. Most commonly seen in the pediatric populations would be classified as otitis media. Sometimes there's trauma behind the eardrum. There could be foreign bodies or just excessive cerumen in the ear. And so it helps the audiologist with additional information regarding some of the location of the site of lesion within the middle ear space. And it also helps us to determine some of the threshold levels, some of the expected threshold levels. It's part of our basic audiological evaluation, and it's part of our battery test. And although it takes a few minutes to conduct, it is it's very helpful in regards to ruling out middle ear pathologies that can contribute to hearing loss. And so I would like to review some of the graphic displays that is used in characterizing the health of the middle ear space. And as you see under the description of a type A, mainly the graph that we use is used to measure the compliance of the eardrum mobility as well as the pressure within the middle ear space. And so we have 5 different graphic displays that is used in the characteristics for the health of the middle ear. Typically, we want to see the type A, as you see in the first depiction of the graph. A type A informs the audiologist that there is no indication of outer ear or middle ear pathology. And so that would be classified as an adequate outer ear and also middle ear. So it rules out any disturbance within the middle ear and outer ear cavity. The type D signifies, as you can see, that like flat line. It shows the audiologist that there is no mobility of the eardrum, okay? And that is most likely consistent with middle ear abnormality. We see that typically with fluid behind the eardrum or something that is occluding the middle ear space and the eardrum is unable to vibrate, okay? It can characterize as a significant hearing loss on our audiogram when we do our measurements. The type C, as you can see, it displays a peak, but the measures are within the negative range of the graph, and it is suggestive of negative pressure. The main characteristics that we see with this type of display is consistent with allergies, a blocked eustachian tube. We also see this type of display with the onset of otitis media or an ear that is resolving itself from otitis media. Okay, and again, this can display in some levels of hearing loss. The type AS we classify as a stiff eardrum mobility. There is limited and restricted mobility of the eardrum. And that characteristic is given to otosclerosis. There could be scarring of the tympanic membrane due to excessive otitis media. At times, if there was a perforation, history of perforation, upon healing, there could be scar tissue over the tympanic membrane that could display in the stiffening of its mobility. And so we typically see that with the type AS that can also display with hearing loss. And lastly, the type AD, which is eardrum that is excessively moving. Okay, a lot of times we see that with trauma, post a motor vehicle accident, and it's mainly associated with the disruption of the acicula chain. And so we do see that as well, characterized with significant hearing loss. And so other than the type A tympanogram, once we see that graphic display, it will signal to the audiologist that there may be some hearing loss within some degree of range.
I just wanted to add that sometimes with the type A TIMP, you will have a conductive hearing loss. And in cases like that, that usually indicates either otosclerosis, or it can indicate something we call superior semicircular canal dehiscence. And in cases like that, we usually refer to ENT so they can rule out that there is an abnormal tear or hole in the superior semicircular canal, which will cause other symptoms like dizziness, hearing loss, balance, things like that. So you can get a type A TIMP with a conductive hearing loss, and that usually means there's something else going on. Yeah. And sometimes with the type B TIMP, we'll get that in a person with who's had a tube put in the ear due to a lot of ear infections. So we'll get that type B TIMP, but we'll get a large volume.
That's right.
Yeah.
And I also wanted to add, we could also see a type A graphic display with hearing loss of the inner ear, which is commonly seen with presbycusis and sensorineural hearing loss. And so that indicates to us that the outer and the middle ear function is within normal, but there is something further with the nerve of the ear that's being impacted. Thank you for adding that.
Sure.
And tinnitus, which is probably a common complaint that you hear with your patients. It can be seen with and without hearing loss, and it is very common. Up to 90% of people with tinnitus will have some level of noise-induced hearing loss. And so it is very common to see that, and now we're seeing it even more. Post-COVID symptoms, we're also seeing it within the younger teenage range. It's very common between the age range of 12 to 17 as they are using their devices at very high levels. And so we're seeing that noise-induced hearing loss with the younger age range. But tinnitus is classified as a disorder defined by the American Tinnitus Association as the perception of sound when no actual external noise is present. Your patients can come in with a perception or description of ringing in the ear, buzzing, a swishing sound, and they could use other forms of descriptions to describe what they're internally hearing. But it is only audible to the patient. And so tinnitus, which the CDC estimates may affect as many as 15% of all people in the United States. So it is a common affliction. It can be secondary, a secondary side effect. It could be an isolated effect. But despite the large number of people experiencing tinnitus, the disorder remains very poorly understood with no cure and few meaningful options for treatment. And so the American Tinnitus Association says that tinnitus can lead to social isolation, anxiety, and often depression. And again, we do see this with hearing loss. And so it can, four major ways that it will impact a patient's functioning ability is just the thoughts and emotions with an increase of anxiety. It's anxiety building because they're hearing the sound in their head, and it could really range in volume. Some people describe it as, very loud, and so it's very specific to the individual. It can be disruptive as a side effect to their hearing, their ability of hearing. So if they have hearing loss, one of the effects of hearing loss, especially within the high range of hearing, is ringing in the ear. It disrupts sleep, being that sleep is, during quiet time, that is when the sound will be a lot more prominent for the patient. And concentration, again, for the same sensation that the ringing is ongoing. So it's very disruptive. So when you come across a patient that does describe, the sense of tinnitus in the form of ringing or swishing in the ear, please refer to audiology immediately, especially if the patient is reporting, the sudden onset of the ringing in the ear, even if it's just single-sided. If they're experiencing dizziness or some form of hearing loss, they have symptoms that are bothersome, again, disrupting sleep, just emotional anxiety ridden, and if they notice possible hearing loss. Although there is no treatment, there are forms of counseling. We do have also diagnostic measures to measure the levels of tinnitus. And so with counseling, we are able to, to give them some modifications and also to provide them with some information to help alleviate the symptoms of tinnitus. And we also have devices that can mask out the sound. Thank you. Now we'll pass this back to you.
So yes, as Ianthe stated, tinnitus is one of the main reasons why patients are referred to us in audiology, and it's true, there is no cure. However, we find that if a patient is complaining of tinnitus at night when it's quiet, what we generally tell them to do is put some background noise, the TV, the radio, white noise, and it usually helps them to sleep at night. Also, if the tinnitus is due to a hearing loss, we recommend a hearing aid, but in addition to it being a hearing aid, it can provide a tinnitus masker. So while the patient is wearing the hearing aid tinnitus masker, because the hearing aid helps to make their hearing normal while they're wearing the hearing aid, they don't suffer the tinnitus. Also, research shows that as long as you don't have a heart condition, if you take the ginkgo biloba, that will help to alleviate the tinnitus. In addition, sometimes ENT doctors will recommend the lipoflavonoid, and sometimes that helps too. Just some of the ways we try to treat the tinnitus. So the types of hearing loss. So how do we determine hearing loss? First, we determine if it's unilateral or bilateral. Does it affect one ear or both ears? And then we determine, is it conductive, is it sensorineural, or is it mixed? So in a conductive hearing loss, that happens when sounds can't get through the outer and middle ear because there's an abnormality either with the outer ear or with the middle ear. So the outer ear, you might have no pinna, you might have an atresia or stenosis, and with the middle ear, as Ianthe pointed out, you may have middle ear diffusion, external otitis, people call that swimmer's ear, impacted cerumen, a lot of wax in the ear canal, eustachian tube dysfunction. So those things will cause a conductive hearing loss. And usually medication or surgery can help resolve this type of hearing loss. In a sensorineural hearing loss, that's when the inner ear, the cochlea, the hair cells, that's when the cochlea, the hair cells, has ear damage, either from presbycusis, you get older, history of noise exposure, ototoxic medication, all those things can cause a sensorineural hearing loss. This is the most common type of permanent hearing loss, and most of the time medicine or surgery can't help, but hearing aids may help. And in the cases where the hearing aids don't help, then we recommend a cochlear implant, and that usually helps. The final type of hearing loss is a mixed hearing loss. So that involves the outer the middle, and the inner ear. So that happens when, let's say, an individual has been exposed to a lot of noise and it's affect the hair cells in the inner ear, and at the same time they've got a lot of wax in the ear or they've got fluid in the ear, causing even more difficulty with hearing. So in cases like that, we refer to ENT. They help resolve the fluid in the ear or remove the wax, and then we give them hearing aids to help alleviate the sensorineural hearing loss. And then we also look at the degrees of hearing loss. So normal would be from 0 to 25, mild 26 to 40, moderate 41 to 55, and so on. And profound 91. In profound, you're hard of hearing or deaf. And I think what I wanted to talk about before I move on to the vestibular portion is something that the audiologists use. I think speech pathologists use it too. It's called the speech banana. And the reason why I like using the speech banana, in particularly with parents of young children, is because sometimes when the kid has a speech delay, either they're not talking or their articulation, their expression is not clear, and the PCP refers them to the audiologist, the first thing the parent will say is, my kid can hear. My kid has no problems hearing. Well, that may be so, but it's important to remember that you can hear in general, but you might be missing out on certain phonemes, certain letters of the alphabet, depending on where the hearing loss is, the level of the hearing loss, and the frequency or pitch of the hearing loss. So, for example, if a child has a moderate to severe hearing loss, they're going to be able to hear the dog barking, they'll hear the lawnmower, but if it's a hearing loss between 250 and 1,000, they're going to miss certain letters. They're going to miss the J if it's a low frequency hearing loss. If it's a high frequency hearing loss, they might miss the sh in shadow or the s in sunshine. So it's very important to rule out hearing loss when a child comes in with a complaint of speech delay or tic or not talking at all. And even though you're born with the hearing, normal hearing, it doesn't mean that over time you won't have a hearing loss. Oh, and this is just going back to what Ianthe was saying about tinnitus and the coronavirus. I just wanted to point out that lately I've been having patients that they complain of tinnitus after having the first COVID vaccine. So I've had 3 cases. One was a teenager and the other 2 were adults. And I tend to find that after the COVID, the first shot, when they start to feel like a cold or flu, I think that inflammation is what causes the tinnitus or the ringing. So in those 3 cases, I actually referred them to ENT. They were given prednisone, and the tinnitus resolved, and the hearing loss also resolved. So just something that we've noticed with the coronavirus and the COVID vaccine lately. I just wanted to bring that up. So just some statistics. Did you know that nearly 30% of adults 65 and older are affected by hearing loss? Hearing loss is the 3rd most common age-related disability suffered by adults 75 and older. Hearing impairment is more common in men than women. Adults with mild, moderate, and severe hearing loss are 2 to 3 times more likely to develop dementia. And 90 to 95 of people with hearing loss can be treated with hearing aids. And if not, we can try cochlear implants. Also, people with mild hearing loss, they are 3 times more likely to suffer from falls than people with normal hearing. And then again, just some better health, better health, total body begins with better health. Did you know that diabetes, hearing loss is twice as common in people with diabetes? Depression, untreated hearing loss gives rise to poor quality of life, isolation, reduced social activity, leading to depression, which Ianthe mentioned, odor toxicity. There are a lot of drugs that can affect the hair cells of the cochlea, the outer hair cells, obesity, smoking. Adults 75 years and older with hearing loss experience a 30 to 40% faster decline in cognitive abilities than their peers with normal hearing. So I'm just going to briefly go over newborn testing, and then I'm going to do the vestibular portion. So 3 out of every 1,000 babies are born with a hearing loss. It's a New York state law. All babies must be fitted with hearing aids by 6 months of age. The goal of the New York Early Hearing and Detection and Intervention Program is to make sure that all newborns are fitted with hearing aids no later than 3 to 6 months of age. This helps in giving the child with the hearing loss an equal opportunity to be on the same level as patients with normal hearing. And its ways we do the newborn hearing test is by either the AABR or the OAE. So generally, the OAE, which is an otoacoustic emissions test, just looks at the hair cells of the cochlea. So generally, it's easier when the baby's sleeping. We put a probe in the ear. The sound goes from the ear to the hair cells. If the hair cells are healthy, they'll respond and send a signal back to the equipment, letting us know that the baby can hear. There's another way that we can check newborn hearing in newborns, and that's by doing an AABR, an auditory brainstem response. Although I really don't like auditory brainstem response because it's not really a brainstem response. It should be an AEP, an auditory evoked potential, because we're actually evoking the potential from the auditory nerve. And that's just another way of looking at whether or not a baby can hear by looking directly at the eighth nerve. And ways we can treat hearing aids is either by giving them an FM unit, hearing aids, or a cochlear implant. And this is just some stats regarding, connection between hearing loss and cognitive delay. Okay, so now, finally, the inner ear. So as I said before, the inner ear has two sections, one for hearing and one for balance. The cochlea is the hearing part of the inner ear. The semicircular canals, along with the otoliths, which are the utricle and the saccule, that represents the inner part of your ear. So I'm going to show you a quick video. Of how the inner ear works.
Deep within each ear, there is a balance system called a labyrinth composed of 3 semicircular canals. These semicircular canals are also connected to the cochlea, which is the organ that allows for hearing. Each semicircular canal is responsible for sensing a particular head direction. Each semicircular canal is filled with fluid, and when displacement of this fluid occurs within the canal, nerve signals are sent to the brain informing which direction the head just turned. The posterior semicircular canal shown here detects when the head tilts down towards the shoulder. The superior semicircular canal detects when the head nods up and down in a yes motion. The lateral semicircular canal detects when the head shakes side to side in a no motion. When a person is dizzy, one of the main tests performed to determine whether the inner ear is the source of the dizziness is the Dix-Hallpike maneuver shown here. The head is turned 45 degrees and the body laid back such that the head is extended about 20 to 30 degrees. If the right inner ear is causing a person's dizziness, eye twitching called nystagmus will occur, a condition called BPPV. Depending on how the eye twitches, specific body maneuvers can be performed to potentially cure a patient of their dizziness.
So, as you can see, the inner ear, the balance portion of the inner ear, is really important in order for a person to have no problems with their balance, dizziness, or vertigo. So if a patient comes and they say they're off balance, or they feel head pressure, or they feel ringing in the ears, or they feel spinning sensation, but they don't feel the spinning sensation in their head, they feel they see the room spinning. All those things are important because it determines where in the vestibular system the breakdown is. Where the breakdown is. So one of the things that I like to ask is, what happens when you're dizzy? Does the dizziness occur when you're getting up out of bed, when you're lying down? when you're walking, when you're reaching up for something, when you're looking down. When does it occur? When is the onset? Was it a week ago? Was it years? Has it been off and on for months? Do you feel like you're floating in the air or that the ground is moving away from you? Do you have blurred vision? Are you disoriented? Do you have nausea, vomiting, anxiety? All those things help to determine the cause of the dizziness. And one of the most popular causes of dizziness is BPPV. And BPPV is, I'm going to skip a little bit, is the, and BPPV is one of the most common causes of vertigo, and it stands for benign paroxysmal positional vertigo. Benign, because it's not due to any serious disease. Paroxysmal, because it usually lasts from seconds to minutes. Positional, because it's only provoked on head movements. And vertigo, because those are the symptoms of the BPPV. So what an audiologist does is we put on these goggles, and with these infrared goggles, we can see nystagmus. Nystagmus is an involuntary eye movement. And based on the Dix Hall pipe, where we put the patient at a 30-degree angle, and we lay them down quickly, their head is hanging, we keep them there, we look to see if nystagmus. If not, we bring them back up, we do it to the other side, look to see if nystagmus. If not, then we know that the cause of the dizziness is not BPPV. It's important to mention that sometimes when you do the Dix Hall pipe, the patient will say, oh, I'm dizzy. But then feeling dizzy and you actually seeing the nystagmus will determine if it's BPPV. So if you see nystagmus, it's BPPV. If you don't see nystagmus, it's not BPPV, even though the patient feels dizzy. And then what we do is if we do see the nystagmus, we repeat it because we look to see if it fatigues. After you do it a couple of times, after a while, they're not so dizzy. When there's a diagnosis of BPPV, what I usually do is refer to the vestibular rehab, and they do certain techniques, either the Eckley maneuver or the Sermont maneuver, to kind of fix the BPPV. And BPPV is caused when the otoconia, which is in the utricle and saccule, they fall out and somehow they fall into the posterior canal. That's what's causing the BPPV. And when those crystals fall out of the otolith and they fall into the canal, you feel the dizziness. And by doing the Eckley maneuver, you're bringing those crystals back into the otolith where they belong. So another disorder that we see a lot in vestibular testing is Meniere's disease. Meniere's disease is a problem where the patient has pressure in the ear, hearing loss, tinnitus, and vertigo. And with the VNG, which is the only diagnostic test that can rule out a bilateral versus a unilateral vestibular hypofunction, vestibular weakness, VNG is the only test that can do that. With the VNG, we're able to see if the patient has Meniere's disease because one of the ears will be weak. And here you see the symptoms of Meniere's disease that the patient will present with. And also with the VNG, because you can't look in the inner ear and see if there's a vestibular disorder or anything, so we use the goggles that helps us to look at the vestibular ocular reflex. And the vestibular ocular reflex, that's a gaze stabilizing reflex. So what happens is that the vestibular system and the visual system, they coordinate with each other through brain pathways to control visual fixation. And that ear-to-brain coordination, that's known as the vestibular ocular reflex. That's ways we can tell whether or not there's a breakdown in the brain. With the VNG, we can rule out peripheral versus central. Is the disorder, is the dizziness, the off-balance, the spinning, is it due to either something peripheral, BPPV, Meniere's, vestibulopathy, or is it something more central, a breakdown in the brainstem, maybe even something like Parkinson's? The VNG can help rule it out. So if you have a patient that's complaining of dizziness, you don't have to refer to ENT to have them referred to us. You can actually just put audiology, VNG on the referral, and if there's a middle ear pathology, Ianthe and I will make sure that instead of doing the VNG first, we'll refer to ENT to resolve that middle ear fluid, and if that doesn't resolve the dizziness, then we'll do the VNG testing. The last page just shows like some things that you can key to kind of see if it's warning signs, if it's peripheral or central. Okay, that's it. Thank you. Thank you.
Thank you, Leah and Ianthe. I know we have a lot of providers here today. Do you guys have any questions regarding audiology, referrals, any complicated patients that you've seen that you might have questions about for the audiology team? Yes, Dr. York.
Thank you, Leah, very much. That was really excellent. Question for you. Within the union patient population, what percentage of the patients have hearing loss related to genetics, trauma, pre-existing medical condition, degenerative? How would you break down our patient population in terms of hearing?
I would say, let's see, genetic, not so much. Trauma, we do have quite a few patients with history of trauma, either head trauma, MBAs, domestic abuse. We do have that population. In terms of, general health, yeah. But we have a lot of patients that complain either brain or vertigo, but we're not getting we have the tools to do the image testing, we're not getting the referrals, and this is something that we have the equipment, we just use it.
Yeah, so I guess that makes a good point. So the types of referrals you think we're missing out on are for vertigo, and what was the other one you mentioned?
Tinnitus.
Yeah, for tinnitus, yes. And I know tinnitus in the older population is very stressful. Yes. And I know last 2 months ago, the physical therapy and occupational team came, and I know they do a lot of work with vestibular system. Do you guys work together, or how does it complement each other?
That's a good question, because what happens is that usually vestibular rehab will wait for the results of the V&G to determine what rehabilitative steps they need to take. So if I diagnose, for example, Ianthe and I diagnose a BPPV, then they know, okay, everything will work. If it's in the posterior canal versus the superior canal where the crystals fall, okay, a Sermont maneuver is indicated at this time. If it's a weakness, then they know to gear their rehab to that. If it's central, then I'll refer back to the primary, so they can be referred to neurology to rule out an acoustic neuroma or something like that.
And I know one of the things I worry about is all the adolescents that use nonstop headphones. Any advice or recommendation, or when do we start worrying about hearing loss, and when should we talk to you guys?
It depends, and it's a good question, because we have noticed an increase in the patients who either complaining of hearing loss or they're complaining of ringing in the ears. So generally I tell the moms, because they're remote, and then they're doing classes remotely, and then they go to the video games with the headsets on, and then they're watching TV, and then they're listening to music, all with the headsets on. So I always encourage moms to give them a break. They give them a break where they're not wearing the headsets. A timeout. But if the child starts to complain, that there's a little buzz in the ear, or they're noticing they're not hearing as well, it's good to bring them in. And anyway, the PEDS department is really good, because they usually tend to come in yearly just to make sure. So that's pretty good, yeah. Because you never know.
I just wanted to add, there are some new stats that now show that 1 in 7 children between the ages of 12 and 17 have some form of noise-induced hearing loss due to recreational activities.
That's high.
Yeah.
That's very
and so, that's very significant. And so, even if the best thing that we could do is identify no hearing loss, but we could then counsel, the parent or the child to put those protection measures on their phones, on their headphones, on their, devices, because there are, now with all of the products, the phones come with those protective noise levels. And so, just creating awareness around it, and like Leah mentioned, with the newborn hearing screening, you could screen them at birth, they could pass the test, but it doesn't mean that there are not evolving issues with hearing and auditory problems as in
Great, thank you. Any other questions? I have two special announcements. I'm very excited to see Dr. Amendola here today, and we are so sad to say that this is going to be her last grand rounds. She has been with the Union and St. Barnabas teams for, I think, over 27 years, he said, and our patient population really love her, and she's been an excellent provider throughout the years to our community, and she will be greatly missed. So I want to say thank you for coming, thank you for everything you do, and you will really be missed. And another announcement is that we have our new provider, our internal medicine provider here with us, Orlando Pinero, and he was a resident of St. Barnabas and did his clinical continuity clinic here, so he's very familiar with our patient population, and we're really happy to have him. So I would take this opportunity to get to know each other. I know there's very few moments that we get to either meet each other within different departments. So this is another great opportunity for a grand round. And Dr. is here, of course, and Dr. York. And
one of our other new providers, Sincere, Vanessa Salcedo.
oh yes, I haven't met you yet. Yes, thank you, Dr. Salcedo. Haven't had a chance to meet you, so it's nice to meet you too. So we are very happy to have you and join the Union Community Health Center team. And thank you again, and we're excited for next month's grand rounds, which will include our vision therapy team. And we are one of the few organizations in the Bronx that actually has vision therapy, and I'm excited to learn more about it next month. So thank you all for coming.
Just one last plug for audiology. I just wanted to let you know that both Leah and I are bilingual, Spanish, English, which is so important and very rare in the field of audiology. And so with our patient base, we are able to service them in its entirety.
And one other thing, since you mentioned the vision therapy, actually the VNG that we conduct, they were the only UCHC facility that performs VNG, and only one of two hospitals in the Bronx that conducts VNG testing. So, yeah.
Good.
Thank you.
Thank you.
Thank you.